What did you say? Sorry.
3 fingers above the shoulder.
And just to remember, I keep telling you, the commonest mistake is the cassette isn't high enough, we don't see T1. If I can't see T1 or T12, I can't figure out how many thoracic vertebral bodies are present, I'm guessing. Okay, the swim lateral, what did we use this for?
What?
You don't know?
You don't see something, I don't think we go through that. Like we didn't go through that.
Okay,
That was to see.
it's to see the cervical thoracic junction, okay? So the area of interest is this, okay? And the swim lateral is, I know we didn't teach it, I thought maybe I mentioned it, it's worth mentioning now. So you wanna get the shoulder, this one back, this one forward, and you're aiming at
Bless
the
you.
jugular notch,
Bless you.
sternal notch. All right, if you wanna see thoracic vertebral bodies, you aim down. If you wanna see C7, you aim up. This is when this technique doesn't work, pull your shoulders back,
Mhm.
and they say, I hurt the base of my neck, that's when you would do the swim lateral. Okay, that's the theory. If you need to know it in clinical practice, get a hold of me and I'll send you the directions via email or something, all right? Chest, we showed you how to take a chest x-ray. We said this is when the patient has this. Okay, now it's an easy examination to do, as you know, but it's a more difficult to interpret. I didn't think it was particularly, it's easy to take with the chiropractic physician be in a situation where you had to do that. I didn't think so for the longest time until this happens. And there's all kinds of other views for the ribs, okay? He took this x-ray, and it's not because it's not collimated, and here's a close-up of it. That's what a rib fracture looks like in its classic location. All right, so for whatever reason, this patient presented, the chiropractor said, it hurts right here, okay? That's a rib, and we always start with a chest x-ray first. You can do this, you can do this, and you can say, I'm gonna take a look at it and decide whether there's something wrong, because when ribs fracture, they fracture here. Or you can say, I don't treat rib fractures, and send them to your favorite institution that will take a rib PA and have a chest for you. Okay? So the interpretation side is difficult. You have to make a decision, or you have to give some thought to where are my limitations going to be. Okay? Now, I don't know why, before we do that. This is the anterior portion of my rib. This is the posterior portion. So it depends on where the rib is injured. Okay? What I've come to realize, if you start with your PA chest examination, all right, and I look at this, and if there is no cortical interruption here that you can see, there's probably not a rib fracture. Now, rib fractures can be subtle. I'm just saying, we all start, whether it's medical, we do rib films or not do rib films, we all start with the PA chest exam. Does that make sense? Okay. So in this case, he's got lots of risk tolerance, this chiropractic physician. He took it and there's a rib fracture. Okay, but as the story evolved, it wasn't because of trauma. She said she hit her chest on the side of the bed. Okay, then as the story evolved, the story was maybe she got pushed into the side of the bed. So what are we thinking?
Domestic.
Abuse, domestic. Okay, now I don't want to open that Pandora's box. We'll talk about that at great length in semester 8, because abuse, especially with kids, means a whole different set of x-rays. This is bad enough. I don't know what they have to do in North Carolina, but this was an occasion where the chest x-ray was needed. This is how it's done. It's easy to do. I don't know whether you think you want the responsibility that goes along with it. I'm just telling you how easy it is to take care from the positioning point of view. Shoulder x-ray. If he can pull his shoulders back, all right, that's a good thing. We don't want portrait orientation. We want this. 40 degrees is a little much. It just has to be minimal, okay? And we'll talk about that in lab so that we can see this well, and we want landscape orientation. Why? Because when you fall on the outstretched hand at the glenohumeral joint, clavicle fractures, okay, and mid-thoracic segments need to be evaluated, as well as lung parenchyma. Before the advent of CT and MRI, there's all these views that were developed. You don't need to know about them. If we start with the standard views and then do the clavicular views, I think that takes you to more than 90% abilities with shoulder x-rays. Lots to know, so the idea is, we want you to think about this. Patients who have shoulder injuries can have AC joint injuries, but they can also have mid-thoracic spondylosis, especially if they're elderly, meaning they have osteospite or spur formation. And you need to know that before you go ahead and do your favorite PA move, in my opinion, okay? So well done, positioning issues could be improved. That's what a baby arm looks like. Always to patient tolerance, okay? All right, we always have rad lines. AC dimension, no more than 5 millimeters transversely, and the dimension from the inferior aspect of the humeral head, the superior aspect of the humeral head, to the inferior aspect of the acromion, no greater than 1 centimeter. If it is, it's probably dislocated or there's some kind of traumatic insult. Okay? Not where the yellow arrow is. This is what a deltoid tuberosity looks like. If we x-ray Dorothy's arm, he'd have a big deltoid tuberosity. That's not normal. I can't tell you how many times they've sent me the x-rays, I think this is a tumor. No, it's a normal variant called the deltoid tuberosity. Okay? Ella may have a small deltoid tuberosity. She's a petite person. Dorothy,
Ella?
on the other hand, big deltoid. Okay? Coronary tubercle, at the inferior aspect of the clavicle, at its mid aspect, you should have a triangular density like this. They can be small, medium, or large, unilateral or bilateral. And it's referred to as a coronoid tubercle. Some people have it, some don't. At the inferior aspect of the clavicle, where the arrows are, it's bilateral and relatively symmetric. A little notch for vascularity, a vascular channel. That's what it's called. Okay? The more likely one is this, the pseudocyst of the humeral head. When I first had this happen to me, I ran to the QP and said, this patient has a tumor. And then they just said, you're a new grad, right? And I said, yes, I am. And I've never made that mistake since. I do some research before I open my mouth to insert my foot. Does that make sense? Okay, so this radiolucency is what the normal humeral head looks like when you put an internal rotation. And it's quadratic, so it could be involving half the humeral head like this, 75% just divided into squares. They can be small, medium, or large. They can't be bilateral, because you're not x-raying both shoulders at the same time. That just means you've done this, and you've done this, and that's how you got these bilateral pseudocysts. It's a normal variant of the humeral head. The amount of cancellous or medullary bone inside the humeral head. It's just turned. Okay? And that causes that phenomenon. Child or adult? Child, because this is a growth plate of the
Growth plate.
humerus. Okay? This is why we do the clavicular examination. If you didn't see that on your shoulder exam, this is the utility of the tangential views of the clavicle. This cortex is intact superiorly. This is not intact. All right? The pencil will break, or bend, and then it finally what?
Right.
Okay? Now the problem with this is, why is that important? It's important in my mind because if this clavicle that is intramembranous ossification, it has less blood supply than a femur that has been formed from endochondral ossification. You've seen people that have the big lumps. That's a clavicular fracture that didn't heal properly. It didn't heal properly because it maybe wasn't set properly, but it doesn't have the healing capability that a normal other osseous structure does. Okay? Now you say, well, that's a big deal. It's not a big deal if the bump comes out at you anteriorly, but if the bump goes posteriorly, what's the problem?
Large lungs.
No, clavicle. Brachial plexus, right? Okay? It's too far superior to be long, okay? But, I mean, in the odd instance or likelihood that it's not gonna be a perfect lump, I'm just saying, it has more neurovascular bundle implications we don't know how it is, what the size of it is posteriorly. But if you see the lump, that would be the problem. And if that patient says, you know what, every once in a while, periodically, I get the neurovascular compression issues of the upper arm, okay? That's what it is. It's old trauma. you want to be able to detect subtle trauma by taking the x-ray of the skeletally mature adult shoulder in landscape orientation. And before I forget, we had a case, a 22-year-old comes to the clinic, she's got an LSTV, that's not the important part. She apparently had some difficult birth, she was born with a cesarean section, but she has brachial issues,
Hmm.
okay, ever since. All
From the
right?
C-section?
That's what we were told.
Wow.
She was born with a C-section or she gave a C-section?
She was born via C-section.
Okay.
And whatever they did in the C-section, her left arm is different than her right arm.
Wow.
Yanked her out.
Okay? Now, somebody could say, you're not supposed to do that in cesarean. I wasn't there. I don't know what happened. Okay? And the dermatologist was taking out my lipoma. He said, it looks straightforward. But during the procedure, he said, it's a little tougher than I thought. He was yanking. Okay? To try and get that thing out. We don't know you won't know what the manipulation is gonna be like until you get your hands on it and start applying some pressure, okay? I'm just saying, we always talk about, you can fracture a collarbone during birth, okay? Or you can have spasmodic torticollis because they had to turn the head. Well, this is an example where this patient has, it was explained to us, brachial nerve injury or brachial plexus issues. I don't know the details of it. She may have forgotten, this is what she was told by her mother.
Hmm.
That's as much as I can tell you of the story. I'm just saying, some of the stuff we read about actually does in fact happen. Okay? So this is a T1 image because it says so. This is T2 because it says so. This is uniformly different because it's a fat suppressed image, and the theory is if there's a disease process where the laser pointer is, it lights up like a Christmas tree. Okay? So we will explore shoulder MRI as far as it would affect you, especially relative to rotator cuff injury, okay? In axial section, so the bicipital groove, that's one of your landmarks for knowing which is anterior and posterior. Okay, this is anterior, this is posterior, this is still the spine of the scapula, just to give you some reference. Okay, a couple more minutes, we're done. So shoulder x-ray. This is not the place to put the marker. You want to put the marker here, but even on a bad x-ray, there's something wrong with the AC joint, yes?
Mm-hmm.
It's done this.
Mm-hmm.
It's separated and become dislocated superiorly, okay?
Mhm.
Now, the problem isn't the dislocation. The AC joint has ligaments, and they're probably either partially torn or completely torn, all right? Someone decided, I didn't know what this was, okay, but when you don't collimate, this patient has had previous cervical spine surgery. This is metal, okay, and because they left the collimation open, okay, these are surgical screws that have been inserted for some kind of repair process to the glenohumeral joint. You, meaning the clinician, the referring doctor, opened the Pandora's box, okay? He has to report that in his document, all right? And this precludes this patient, this precludes the patient from having the X examination, right? You know that. So if you want to get yourself into hot water, leave your collimator open, and now you're responsible for everything on the film, okay, besides spine stuff. And even though they've had surgical procedure, surgical sutures can fracture and break. This is not the best shoulder film. It needs to be fixed, and the first thing we fix is KVP. Okay? Back in the old days, we had to decide how much KVP we needed. Now, with the new digital systems, you have to decide, is your patient small, medium, and large? When in doubt, go to the next size. Miss L is small. Jeremy, if I'm not sure if you're small, okay, in some ways you're small, in other ways I'm going to go medium setting, and the computer sets up the factors for you. Okay? But even on a bad film, the metal is fractured, and if you hallucinate where the laser pointer is, right here, that's an osteophyte or a spur coming from the inferior aspect of the distal clavicle. What runs this way? Rotator cuff. And if this is big enough, it can irritate rotator cuff. Okay? Well, I have to go ahead and clean it up. This is the previous one. It will emphasize to you, make sure you find out whether it's a child or an adult. It's a child in the growth plate, and that information hides in the corners. Okay, and this is not an unusual injury with little people. This shoulder was traumatized. Why? Because there's osteophyte or spur formation of the inferior aspect of the humeral head, but there's also osteophyte formation of the inferior aspect of the labrum. So this is this type of injury into some object or something that didn't move, okay, or you fell down, lateral compression. Now, that's what we see. What about the superior, inferior, middle, and inferior glenohumeral ligaments? That's all been torn, as well as some of the holding structures around the glenohumeral joint. This is old chronic injury. Okay. Last but not least, landscape orientation. That's not what the inferior aspect of the acromion process should look like. So prior acromial injury, and again, my inferior portion of my humeral head, and then these subchondral cystic change or these radiolucencies are not normal, okay? And then when you look at the mid-thoracic spine, spur formation, spur formation, spur formation. Your PA favorite move may not have the same effectiveness as someone who doesn't have that, okay? Calcification where there should be calcification. And even though the film is underexposed, this is the visual of where the subacromial, subdeltoid bursts are with or without a communication. That's what it looks like from a straight AP view. Another example, can everybody see where the pointer is? On your
Yes.
device, that's bursal calcification. Now you know that why it's bursal. Okay, and just before we leave that, another example. Look this way, there's nothing wrong with the clavicle, but there's little bumps here. Those are osteophyte formation that comes in semester 8. I appreciate that, but even now, that's one of the logistical reasons why we do landscape orientation. And you want to start from the outside and go all the way in, or start from the inside and go all the way out to make sure your search pattern covers all those bases. Okay.
Mhm.
Quickest shoulder hour I've ever had